Hmm. All right. So, in the last video, we knocked out the big guys, Crohn and ulcerative colitis. All right. So we're done looking at the esophagus. We're done looking at the stomach and all the ulcers you can get there. We're done looking at the big guys about regarding the colon. Now we're gonna see some of these other less, I guess, less devastating but equally as problematic bowel syndromes, right? So there's a bunch of things that can happen in your intestines, and you do need to know all of them, because the thing is that you'll get questions where pretty much majority of them will be your answer choices, so you have to be able to make the differentials. This first one here is pretty easy. This isn't that complicated, but it is a pretty common thing, and it does happen to a lot of people. Often it just goes misdiagnosed or undiagnosed because it's not like it's something that's killing the person, but it does affect the person's lifestyle. So irritable bowel syndrome is recurrent abdominal pain associated with two or more of the following. It's going to be related to defecation, there's going to be a change in stool frequency, and there's going to be a change in form or consistency of the stool. There are no structural abnormalities, and that's something that has to be given to you in the question. So colonoscopy, endoscopy, there has to be nothing wrong. X-ray, like it all looks perfectly fine, just like any other human that has no issues in their GI system. It's most common in middle-aged women, but it can definitely occur in men too. You'll have chronic symptoms, which can be diarrhea predominant or constipation predominant or mixed, right? So you might be like constipated during the daytime and then have diarrhea during the rest of the day. Pathophysiology is multifaceted, and the first line treatment is lifestyle modification and dietary changes. So the main thing here is that it has a huge psychiatric component, right? So goal here is symptom control. Note there is no rectal bleeding, tenesmus, weight loss, greasy stools, or any other red flag symptoms that we've seen so far. All you're going to have is a patient who ends up having weird pain because they're either too constipated or having too much diarrhea at different times of the day. The psychiatric component to this is that oftentimes it'll be related to some kind of big stressor, like maybe this person is going through a divorce or recently lost their job. Something like that is happening, right? And the change in form consistency and change in stool frequency, those changes often also tend to pop up right when the person is about to engage in something that they're really stressed out about, like going out on a date, for example, right? So that's kind of what you're going to be watching out for IBS. Appendicitis is usually a really big differential for many of the different things that can happen to a person. Appendicitis is an itis, so it's acute inflammation of the appendix, which is being shown with the yellow arrows here. And it can be due to obstruction by fecalith or lymphoid hyperplasia. Now, if it's an adult, then it's probably going to be due to obstruction by poop in the colon. But if it's a younger child, then it's usually going to be because of some kind of infection causing ileal hyperplasia, all the Peyer's patches in the ileum. Proximal obstruction of the appendiceal lumen produces closed loop obstruction, leading to increased intraluminal pressure, stimulation of visceral afferent nerve fibers, initial diffuse periumbilical pain, and then inflammation extending to the serosa and irritating the parietal peritoneum. So there's a lot of nerves being mentioned here, right? But remember that we talked about the nervous supply, about how everything up to, I guess, the first part of the transverse colon was vagus nerve, and then after that there were different nerve fibers. So that's kind of what we're discussing here. So now we're looking at visceral afferent nerve fibers of T8 to T10. All right, so you definitely want to keep that in mind because that can be a question, and you could have to pick that as an answer choice. Pain is localized to the right lower quadrant and then the McBurney point, which is 1/3 the distance from the right anterior superior iliac spine to the umbilicus. Nausea, fever, it may perforate leading to peritonitis. It can also elicit the psoas, obturator, and Rothsing signs of guarding and rebound tenderness on exam. Right, so these are all different things you can see, and I'm going to talk a little bit more about it right now. So main thing is, if a patient does have appendicitis, if palpation of the left lower quadrant of a person's abdomen increases the pain felt in the right lower quadrant, the patient is said to have positive Rothsing sign and may have appendicitis. Right, so this is a really interesting kind of sign. You can look it up more. You can also watch YouTube videos about it. Now, as I said, there's a bunch of differentials that you have to rule out anytime you have a patient presenting with some, with the clinical picture of appendicitis. Diverticulitis, if it's a really elderly patient. Ectopic pregnancy, if it's a younger female. And pseudoappendicitis. You have to rule out all of these things because appendicitis itself often requires surgery, and you don't want to send this person to surgery without ruling out every other possibility. So here I kind of talk about the nervous system supply of stuff that was being mentioned right now. So the initial abdominal pain is visceral pain due to luminal distension and stretching of smooth muscle, and is carried by the general visceral afferent fibers of the autonomic nervous system. The pain usually occurs in the midline region and is poorly localized. Patients also develop nausea, vomiting, and sweating due to autonomic stimulation. Later, somatic pain occurs due to the irritation of the parietal peritoneum and is well localized, more severe, with rebound tenderness at the McBurney point. Afferent fibers enter the spinal cord at T10 or T8 to T10, and the referred pain is going to be at the umbilicus. Alright, so that's the stuff you want to make sure you know. So when they're talking about referred pain, when they're talking about the McBurney point, all of that is somatic pain. The initial stuff that occurs, the initial abdominal pain, that's the visceral afferent fibers. So make sure you know the difference between the two, and you can actually pick one over the other. The latter half of this page talks about diverticulitis, right? So various diverticula of the GI tract, which is really just an outpouching like this. So diverticulum, as you can see in this picture, is literally going to look like that, right? So you see the outpouching here. It's a blind pouch protruding from the alimentary tract that communicates with the lumen of the gut. Most diverticula, either in the esophagus, stomach, or duodenum, or colon, are acquired and are termed false diverticula. Right? A true diverticula would have all gut wall layers outpouching, and that's your Meckel's diverticulum. The only real true diverticulum you need to know about is the Meckel's diverticulum, not many of the other ones. False diverticulum, or the pseudo-diverticulum, have only the mucosa and submucosa outpouch, and this occurs especially where the vasa recta perforates muscularis externa. So basically what they're saying here is, how do you decide where an outpouching like this would happen? Well, it's basically where the veins are located, right? So wherever the blood vessels are located, there's a weaker wall, and then if there's enough pressure inside the colon, you can have an outpouching. And this image here kind of shows you the difference between true versus false. Right? So you can see that a true diverticulum has the whole thing, all the layers, right? So mucosa, submucosa, muscularis, and the serosa. But in the pseudo-diverticulum, right, you don't have that. You only have the mucosa and submucosa, but the muscularis doesn't go out. Diverticulosis is when you have many false diverticula of the colon, and that's kind of what you're seeing here. See, one diverticulum is just one, but when you have multiples, that's diverticulosis. And it's usually going to be in the sigmoid colon. Common in about 50% of people over age 60. Caused by increased intraluminal pressure and focal weakness in the colonic wall, especially where there are perforations of the vasa recta. Associated with obesity and diets that are low in fiber and high in total fat and red meat. Often asymptomatic or associated with vague discomfort. Complications include diverticular bleeding and diverticulitis. Alright, but this is important. Anytime you got a patient that has bleeding in their GIT, you want to consider if it's painless bleeding or there's pain, right? If there's abdominal pain, that's a whole different set of diagnoses you look at. But if it's painless bleeding, then you have diverticulosis and many other different set of differentials to look at. This is one question from USMLE RX regarding diverticulosis, who says, a 68-year-old gentleman presents to the emergency department with 3 episodes of painless bright red blood per rectum and lightheadedness, obviously because of losing blood and the anemia that the patient is developing at that point. He has noticed no change in stool caliber or weight loss and had a colonoscopy last year without any evidence of colon cancer. By frequency, what is the most likely diagnosis? Right? And usually the question would just say what is the most likely diagnosis, and you're supposed to figure it out by frequency all the time as it is. So he's 68, which means he fits the category of being over 60, and he has painless bleeding, but there's nothing else that's wrong. Then it has to be diverticulosis, right? And that's really all they're trying to teach you in that one question. The last thing here is diverticulitis. This is an inflammation of the diverticula with wall thickening, classically causing LLQ, lower left quadrant pain, fever, leukocytosis. you have to treat this with antibiotics. So it's really important to make sure you remember that, because oftentimes when we think of inflammation, we think of using corticosteroids, right? And you will have a lot of corticosteroids in your answer choices, but don't pick one of them. This actually requires treatment with antibiotics. So what are complications you can have if you have inflammation of the colon? Well, we saw in our Crohn disease, right? If you have inflammation of the colon and you have things like this happening, then you can have a connection between two different parts of the colon and you make a fistula, right? Especially if you make a colovesical fistula where the colon connects to the bladder, that's really going to be very problematic, and a lot of infection is going to be possible now. You can get abscess formation, obstruction, or perforation, all of which is going to lead to different kinds of issues, and you're supposed to be able to diagnose the patient with diverticulitis, right? So that's really all that's happening there. One question that UWorld had that was pretty interesting because they tried to use this word. Remember, when you look at a diverticulum, right, you can kind of tell that the only reason this would happen is because there was a lot of pressure in here, right? There's so much pressure in here that it's trying to expand the colon, but the whole colon can't expand. However, parts of the wall that are weak just plop out, right? That's kind of what's happening in there. So this question says, make it a little bigger. This question says, a 74-year-old man is evaluated in the clinic due to an episode of bright red blood per rectum. The patient has no dizziness, weakness, or exertional dyspnea. He has a history of hypertension for which he takes benazepril. Such a weird pril medication too, like why couldn't they just put lisopril? The patient does not use aspirin or any anticoagulant medications. There is no history of colon cancer in the family. Blood pressure is 145/90 and pulse is 70, so his blood pressure is kind of high. On colonoscopy, he is found to have several small pouches protruding from the lumen of the sigmoid colon. So when you have several small pouches, you know that's diverticulosis, and he's 74, so he again fits the age group of being over 60. The walls of these pouches are composed of mucosal and submucosal layers that are covered by serosa, but there's no muscularis, right? So that means it's a false diverticulum. The patient's diverticula are best described by which of the following terms? Right, this patient's diverticular. So the answer was pulsion. Of all of these words, of course, a lot of people pick true, but you know it's not true. This is a false diverticulum because it's only the mucosa and submucosa. And then the only other word from these answer choices that have anything to do with pressure inside the lumen is pulsion. Right, so that's why this is a pretty interesting question, because they have that wording there. And you have to watch out for certain words like that. I'm going to come back to this question. Let's take a look at this stuff happening on the next page. So the next page talks about other diverticulums that you can have. You have a Zenker diverticulum, which is also a false diverticulum, and then the Meckel diverticulum, which is the only real one you need to worry about as far as a true diverticulum is concerned. The Zenker diverticulum is a pharyngoesophageal false diverticulum, just like this image right here. Right? Esophageal dysmotility causes herniation of the mucosal tissue at the Killian triangle between the thyropharyngeal and cracopharyngeal parts of the inferior pharyngeal constrictor. Presenting symptoms are going to be dysphagia, obstruction, gurgling, aspiration, foul breath, and a neck mass. This is most common in elderly males. Alright, so you get this weird kind of outpouching that you're seeing right here. Right, this is pretty nice, the elder Mike thing. Elder Mike has bad breath, so it's going to be elderly males. It's going to be at the inferior pharyngeal constrictor. It's inside the Killian triangle, and this causes esophageal dysmotility because what happens is when you eat food, when you swallow it, a lot of food just tends to get stuck there and hang out right here. Right? It just gets stuck in the pouch and hangs over the little ledge right here. And if food just hangs out right there, that's the reason these people have halitosis, smelly breath. Alright? And up here is another image where I'm showing you the same thing they're showing you here. This one is just pretty much an x-ray. Here, this one is showing you a barium swallow. Right, so the person swallows some barium enema, and then you can see that you have this pouch at the back of the neck, right, in the esophageal area. So that's pretty much a giveaway at that point that this person has a Zenker diverticulum. This question is also about a Zenker diverticulum. So it says a 74-year-old man comes to the office for months of choking spells, dysphagia, and cough. He has also had recurrent episodes of pneumonia. His other medical problems include hypertension and osteoarthritis. Blood pressure is 130/70, which isn't that bad. He has foul-smelling breath, but his oropharyngeal and neck exam are normal. A barium swallow study is performed and reveals an abnormality. An image like image A below is given. what mechanism is the most likely cause of his symptoms? And the answer was cricopharyngeal motor dysfunction. Now, the reason this question is nice to have here is because it paints a really nice clinical picture of things that are not mentioned in the book itself. So this patient also had recurrent episodes of pneumonia, right? And that's something you want to keep in mind because, of course, with food getting stuck here and these recurrent choking spells, because he's also breathing, oftentimes a lot of the debris from the food might actually end up going into the lungs, right? And that's going to lead to practically aspiration pneumonia type of issues. So that's something worth noting. And let me see. Oh, and then the neck exam, right? So this was really interesting that they said that the oropharyngeal and neck exam are normal, right? Which makes sense because when you do a neck exam, you can't really see inside and look at this pouch. So be wary of that. Don't look for someone telling you that the neck exam is not normal. That doesn't necessarily have to be given to you. But a barium swallow will definitely reveal what's happening. Okay. This one's really a big deal. Macrodiverticulum is extremely popular on step 1 because it's also related to a lot of reproductive stuff. So here you have a true diverticulum. So at this time you also have the muscularis coming out in the outpouching. Persistence of the vitelline duct, also known as the ophalomesenteric duct, may contain ectopic acid-secreting gastric mucosa and or pancreatic tissue, which you can already imagine must be painful, right? So if you have gastric or pancreatic tissue at places where they're not supposed to be, then you're going to have enzyme secretion and acid secretion at places you don't need it. And that's going to hurt, that's going to cause bleeding, it's going to be very bad. Most common congenital anomaly of the GI tract, which is why it's very popular, right? This is the most common GIT congenital anomaly. Can cause hematochezia, melena, right lower quadrant pain, intussusception, volvulus, or obstruction near the terminal ileum. Remember that when something like this is sticking out now, it gives your colon something to wrap itself around, right? And if it wraps around this, you can get intussusception and volvulus, either one of those things. Contrast with an ophalomesenteric cyst, which is simply a cystic dilation of the vitelline duct itself. How do you diagnose Meckel diverticulum? They're always going to mention this to you, and if they don't, then they'll tell you something else about finding gastric mucosa. But generally speaking, the 99M TC pertechnetate scan, also known as the Meckel scan, and I have a picture of it right here, will show you heterotropic gastric mucosa uptake, right? Now, where would you see this uptake? So that's what this image kind of shows you, right? To make it very clear, the uptake would be right here, right? Normally, you have pertechnetate uptake in the bladder and in the stomach, so that's fine. If you have a third one, that's your Meckel diverticulum, which is sort of in the right lower quadrant area. So this is how a Meckel scan kind of looks like. They're always going to look the same way like that. The rule of twos is kind of useless. Like the only twos that are good here are that it's 2 times as likely in males. 2 inches long, not necessarily a big deal. You know it's an outpouching. 2 feet from the ileocecal valve, that's pretty helpful to remember because you can have blockade, right? Obstruction near the terminal ileum. 2% of the population basically tells you it barely happens, but at the same time, 2% is still also a big population because if you're talking about the whole population, 2% is a lot of people. But generally speaking, 2% is just 2%. It's not like 5 or 10. Commonly presents in the first 2 years of life and may have 2 types of epithelia. So, you know, the rule of twos, you don't really need to know the whole thing. I find rules like this or any, you know, memorization methods like this to be a little foggy because they can really confuse you because you might end up worrying too much about remembering all the twos. Generally speaking, all you really need to remember is the stuff on the left side, right? You need to know that it's an outpouching, which is a true diverticulum. It has the muscularis in it. It's happening near the end of the colon, so near the, you know, the end of the ileum, I mean. And at that point, because it's an outpouching near the end of the ileum, you can have a bunch of issues regarding blockade, volvulus, any of that stuff. And you need to remember that there's going to be ectopic acid-secreting gastric or pancreatic tissue, right? And that's literally what you diagnose it with. Now, this image here shows you the other guys, right? So you can see the Meckel's diverticulum, same picture as this one. This here is a fistula. So this is supposed to be your umbilicus. If the Meckel diverticulum got longer and actually connected to the umbilicus, and there was enough inflammation, you could have a fistula very easily. This is a cyst. The other thing they're trying to tell you to look at, right? They said to look at the ophalomesenteric cyst. So that's what that is. Now, a cyst will basically be something you can palpate. If you palpate in that area, you'll feel that ball. And this thing here is not that significant. It's just a fibrous band and adhesion. The only reason this is significant is because things, again, can wrap around the adhesion itself, and that's going to be problematic, right? You don't want things wrapping around anything, because your intestine is a free-flowing organ. It's just there, and food is always moving around in there. If it wiggles enough and wraps around something else, it can just choke itself, and then food is going to get stuck, and that's going to be really bad. So how does this present in a question? So this is what this question is about. So this is from Amboss. It says a 15-month-old girl is brought to the physician by her mother for grossly bloody diarrhea for 2 days. The girl has had a few episodes of blood-tinged stools over the past 3 weeks. She has not had pain, nausea, or vomiting. She's at the 55th percentile for height and 55th percentile for weight. Examination shows conjunctival pallor. The abdomen is soft and non-tender. There's a small amount of dark red blood in the diaper. Her hemoglobin is 9.5. Mean corpuscular volume is 68, and platelet count is 300,000. Further evaluation is most likely to show which of the following findings. And then the answer was ectopic gastric mucosa on the Meckel scan. She has a Meckel diverticulum. Acid secretion by that gastric mucosa results in ileal ulceration and bleeding, also causing microcytic anemia as seen. So what's cool about this is that Meckel diverticulum is pretty much equivalent to almost like the symptoms of colon cancer, but in newborns, right? Colon cancer presents very similarly to this, right? You have bloody diarrhea, or you have occult bleeding in the feces, and then you get iron deficiency anemia, right? But the platelet count should be about normal, and that's really all you're noticing, and nothing else happens, right? No pain, nausea, vomiting, etc., etc. So this is basically, Meckel diverticulum is basically the same thing as having colonic polyps and occult bleeding in patients who are at risk of colon cancer, but now we're seeing it in infants and newborns, alright? So very much the similar clinical picture, just a different age group, completely different age group. And the root cause of it is a very different thing too, right? So now it's a true diverticulum, a Meckel diverticulum from the persistent vitelline duct, alright? The next one is also for kids, basically. So this is also pediatric. Hirschsprung disease. And I have a bunch of histological images that I'm going to go into because you should know the different histological things that are associated with Hirschsprung. You can just get either one of these two images, the one on the left or the right. The middle one is normal. And it's not very HD, but it was the best picture I could find to show you what I want to show. So what is Hirschsprung? So you can see from the picture already, the drawing they made. It's a congenital megacolon characterized by lack of ganglion cells or enteric nerve plexuses, the Auerbach and Meissner plexuses, in the distal segment of the colon. This is actually due to failure of neural crest cell migration, right? Because neural crest cells are the ones that are going to bring the Auerbach and Meissner plexus into your colon. Associated with the loss of function mutation in RET, right? We've talked about RET mutations so many times so far, and sometimes it's a gain of function mutation, sometimes it's a loss of function. RET oncogene encodes a receptor tyrosine kinase, and the loss of function leads to Hirschsprung, right? There's another disease, I can't remember what it was anymore right now, but we spoke about it earlier. It was also related to RET, and it was a gain of function. Presents with bilious emesis, abdominal distension, and failure to pass meconium within 48 hours. This eventually obviously leads to chronic constipation, and you can see the whole thing is distended now because all the feces is kind of backing up. The normal portion of the colon, proximal to the aganglionic segment, will be dilated, resulting in a transition zone. Risk is high with Down syndrome, so usually the question will mention symptoms or signs of a patient with Down syndrome. Explosive expulsion feces when you do the rectal exam, the digital rectal exam. So basically when you finally kind of open this up, all of this just bursts out, right? And that's what they're calling the squirt sign, such a weird name. Diagnosed by absence of ganglionic cells on rectal suction biopsy. And treatment is just to resect this entire portion. This tiny portion right here that has no nerves, you basically just get rid of it and connect whatever portion was normal. So what's important here? Alright, we have these two images, alright, and they said that diagnosis is by absence of ganglionic cells on the rectal biopsy. So this on the left is your rectal suction biopsy. And when you look at this rectal suction biopsy, you can tell that this is from the colon because, first of all, this is super thick, right? And your colon is thick. Your small intestine is not that thick, the jejunum, ileum, and all that. We looked at a lot of histology in the earlier videos when we were doing gastrointestinal anatomy. The colon is the only one that's this thick, and also you have a ton of mucus secreting cells, right? Which is what the colon has. The colon is full of goblet cells because you need to secrete a lot of mucus to make the feces kind of flow out easily during defecation. What you're not seeing in this image is any nerve cells under here. So these things that you do see here, these are not nerves, right? These are not nerves. What do the nerves actually look like? Well, this is H&E staining. When you do H&E staining, right, you should see purple things, right? Everything here is pink. Everything in this bottom portion is pink. Everything up here is purple, but there's nothing purple down here. In this image, you can see it, right? You see the tiny dots? Those are all your ganglions. Those are purple. Those are the tiny nerve plexuses that do your Auerbach and Meissner plexus work. And you see how they stain purple with H&E? But in this image, you don't have anything staining purple with H&E, so you can already establish that this patient does not have the Auerbach and Meissner plexuses in their distal ileum. No, sorry, not distal ileum, distal colon, right? In the sigmoid colon area. I remember that this is part of the colon, not your small intestine, and it's always going to involve the very ending. You could kind of see this arriving at the transition zone now, right? The anal rectal transition zone. So it's always going to involve the ending, and that's why you do a rectal suction exam. You're basically taking a biopsy of some end portion over here. This image here talks about a different thing that First Aid doesn't mention, but you can find it all over the internet. So in this right image, you're seeing aberrant acetylcholinesterase positive fibers in the lamina propria. Normally, there are no nerve fibers detected in the rectal area, right? So acetylcholinesterase fibers, if you're finding fibers from acetylcholinesterase here, that's all the stuff that's staining brown. Everything that's staining brown down here, all your acetylcholinesterase fibers, they're not supposed to be there. Right? So that's another more recent thing that is starting to come up for Hirschsprung disease, and people are starting to use it as another diagnostic factor. So basically you would have two things that you could do to confirm that a person has Hirschsprung. I mean, it's really not going to be that hard to confirm Hirschsprung, but if your test mentions anything about an acetylcholinesterase positive fibers in the rectal suction biopsy, and they give you an image like this where you see a bunch of brown stuff down here, that means that this patient has Hirschsprung. Right? There should not be any acetylcholinesterase fibers here. Normally, there are no nerve fibers detected in the rectal area. All you're supposed to have are your Meissner and Auerbach plexuses, which are different from nerve fibers. This question talks about something I just said, where I was like, the rectum is always involved. So this question was interesting. They started this in a really weird way. They said that it is suggested that some unknown factors may specifically interrupt the normal migration of neural crest cells to the intestine. The migration process is typically complete by the 12th week. If the progress is interrupted during the final week of migration, what organ is most likely to be affected? And the answer was the rectum. Right? But 32% of people chose the sigmoid colon. But the truth of the matter is that Hirschsprung always involves the rectum. You see, they tell you it's a collapsed rectum. So when you do the resection, you have to resect the rectum and then whatever portion of the distal colon that doesn't have nerves. Hirschsprung is due to the arrest of migration of neural crest cells. So a segment of colon is deprived of ganglion cells. So the colonic wall cannot relax. Passage of contents is difficult past this narrow area, leading to dilatation of proximal areas. The rectum is always involved, and anal sphincter tone is increased, right? This is heavily contracted here, so you can't really pass feces. Rectal biopsy reveals aganglionic segments of bowel, which is what we're seeing here. Right? You're not going to see any ganglions here. Nothing is staining purple down here. Right? So that's pretty much all there is for that. On the next page, they talk about malrotation and intussusception. Malrotation can be due to other things, right? So it's an anomaly of midgut rotation during fetal development, and they have this cartoon image and an x-ray showing it to you. So you basically end up having improper positioning of bowel. The small bowel will all be clumped to the right side. So you see you have your, after the stomach you got your duodenum, and then everything from the duodenum, jejunum, ileum, it's all just stuck on the right side, under the liver. And then finally it connects to your colon, and your colon is kind of just pushed over to the left. So that's kind of what you're seeing here too. Alright? So really important to note that. And one thing they love asking about are these fibrous bands. These are bands that are connecting the colon to the liver, oftentimes also kind of constricting this duodenal area. There are many pictures of lad bands on the internet. You can find they're all drawn pretty much the same kind of way, but generally speaking, it's a connection of the colon into the liver. All right, can lead to volvulus or duodenal obstruction, right? Because the duodenum can be obstructed by the lad band, and you can get volvulus because all the small bowel that's now on this right side of the patient can just twist and turn and rotate into itself. Intussusception, as you can tell from these pictures, is pretty painful. It's a telescoping of a proximal bowel segment into a distal segment, commonly at the ileocecal junction. So basically, the colon, the small intestine kind of went into itself, and that's really painful. There's going to be compromised blood supply that's leading to intermittent severe abdominal pain, often with Crohn jelly, dark red stool. Crohn jelly just looks like grape jam kind of stool. Majority of cases in children and unusual in adults. It really won't happen in adults at all. Often due to a lead point, but can be idiopathic. Most common pathologic lead point in children is going to be the Meckel diverticulum. In adults, it'll be an intraluminal mass or tumor. On physical exam, the patient may draw their legs to their chest to ease the pain. And you feel a sausage-shaped mass on palpation, right? Because this is going to be really thick. Because it was supposed to be just one lumen, now it's like a double lumen, it's a double layered lumen, so it gets really, really thick, and you can feel it when you palpate their abdomen. Imaging, such as an ultrasound or CT, may show the target sign. Right, so you can see in this ultrasound right here, you have the target sign, and image B, again, you can see the target. Right, so it's just lumen inside the lumen, that's all you're really looking for. They talk about things that it might be associated with. So far, when we were in microbiology, we did see that there were two things in microbiology that could lead to intussusception. One was recent viral infection, like adenovirus or anything that could cause peripatch hypertrophy. The second thing was actually using the vaccination for RSV. Let's kind of take a look at that real quick. So if we go back to microbiology, we look at viruses, we get to RSV, let me see, I think it was, yeah, this one right here. Right, so this is the picture, respiratory syncytial virus, where they talk about it. Or was it rotavirus? I think it was rotavirus. Oh, it was rotavirus, yeah, my bad. It was rotavirus. So rotavirus, which is a segmented double-stranded RNA, a reovirus, which is for reovirus is repeatovirus, right? So double-stranded DNA, double-stranded RNA. Rotavirus is the one where this is the most common, most important global cause of infantile gastroenteritis. This is usually something you give vaccinations for, and they tell you CDC recommends routine vaccination of all infants except those with a history of intussusception or severe combined immunodeficiency, because the rotavirus vaccine can actually cause intussusception. It's not really known how. Usually such a thing would be related to peripatch hypertrophy as well, so it could be that. But generally speaking, if you do get a question on this, then you make sure you pick that. Now, although the book says this is the most important global cause of infantile gastroenteritis, rotavirus is usually, not that popular anymore. It's not that common to get rotavirus. So unless you have other answer choices that make more sense, rotavirus is the answer you go with. But adenovirus is usually going to be the one that actually causes infantile, often bloody diarrhea. Right? So you want to make sure you get that. But that's just something I wanted to make sure I came back and reminded you guys of. So rotavirus, which is a real viridae. And then down here, what are we looking at? Necrotizing okay, I'll come back to that. That stuff is related to other intestinal disorders. The last thing, which I really wish they just fit right here, is your volvulus. Right? So volvulus is a twisting of a portion of bowel around its mesentery. Can lead to obstruction and infarction. Can occur throughout the GI tract. Midgut volvulus are more common in infants, and sigmoid volvulus is more common in the elderly. So what they're showing you here is your sigmoid volvulus, right? So the large intestine, the sigmoid colon, has somehow found a way to twist up into itself. The other image I put right here is a midgut volvulus, right? Where you're seeing the small intestine is kind of twisting up in itself, but the large intestine is okay. Now notice how this is also still pretty similar to what happened with malrotation, right? Malrotation can lead to volvulus. So you have in malrotation, your small bowel is on the right side, and then it can twist up like this, right? So that's really problematic. That's also painful, and the twisting causes strangulation. So any food you're ingesting won't really pass all the way, and it'll then end up coming back up, and you'll have bilious vomiting. This one here is showing an infant, right? You could tell this is a really small, tiny rib cage, and in this infant, you're basically seeing midgut volvulus, right? All of this is kind of twisting up on the right side. This bigger X-ray here is showing you a coffee bean sign. Coffee beans do kind of look like this. I find it a weird thing to call it anyway, but generally speaking, here the issue is on the left, right? Whereas in this one, the issue is on the right. Here the issue is on the left. There's nothing major happening on the right side, so you know this is a sigmoid volvulus, and it's going to be an elderly patient that has that, right? Volvulus patients are usually going to present just with food not passing correctly, right? So you would have an elderly patient with symptoms very similar to Hirschsprung because food reached the colon but is not going past it. So all the food is now stuck in their large intestine. Now, other intestinal disorders. These are really interesting. I've seen a lot of these being tested. UWorld has a lot of questions on these guys too, and so did AMBOSS. First one we see, acute mesenteric ischemia, and AMI, right? So this is very similar to a myocardial infarction, but it's also MI, so you'll be able to remember that. There's acute MI and chronic MI. The acute mesenteric ischemia is a critical blockage of intestinal blood flow, often because of some kind of embolic occlusion of the superior mesenteric artery, leading to small bowel necrosis, abdominal pain out of proportion to physical findings, and again you'll see that Quran jelly, kind of like grape jam looking stool. Patients will complain of extreme pain like a 10 out of 10, but the physical exam will be perfectly normal, right? So what happened here, something occluded the SMA. Very similar to how something can occlude your coronary arteries, something occluded the superior mesenteric artery, and now you have ischemia because there's no blood flow, so the rest of your intestine isn't getting its blood supply. In chronic mesenteric ischemia, this is actually even referred to as intestinal angina. UWorld had a question where they talked about it as intestinal angina. They actually compared it to chest angina and really wanted to make you understand that you have to be able to pick the chronic mesenteric ischemia as a choice. So it's very similar to an MI here too. You have atherosclerosis of one of the three vessels that supply your GIT, right? This leads to intestinal hypoperfusion, which leads to postprandial epigastric pain. And now you're not going to eat. Every time you have postprandial pain, anything that causes eating to be related to pain causes you to eat lesser, right? So food aversion and weight loss. Patient may have generalized atherosclerosis with a history of coronary and carotid artery disease and hyperlipidemia, which is really important to understand, right? If you have atherosclerosis of one of these three guys, then you definitely, by this point, have atherosclerosis of your coronary artery or your abdominal aorta, something, right? Because atherosclerosis here should not be that easy. So these two guys are pretty high yield, they're pretty common. Adhesion is just a simple thing. It's a fibrous band of scar tissue commonly forming after surgery, right? A patient might have had surgery because they had Crohn disease, ulcerative colitis, or maybe they got surgery to lose weight, so they got the gastric sleeve, anything like that. Or it could also be after a reproductive surgery like a hysterectomy. So what happens here? Fibrous band of scar tissue commonly forming after surgery is the most common cause of small bowel obstruction, demonstrated by multiple dilated small bowel loops on x-rays, right? And that's kind of what they're pointing out here. So this is your small intestine kind of looping around, right? And that's why you have the yellow arrows pointing at the beginning of each loop. And all your small intestine is kind of looping on the right side, right? It's all staying on one side, it's not going to the other side also. So this patient might have a history of some kind of GIT surgery, and that's how you know that this patient has adhesions that led to this, right? Image A was showing you the bleeding. You see this? This is ischemia right here, right? So that's your necrosis of the small bowel because of the ischemia. So you can see the blood and the fact that it's now kind of starting to turn black. Angiodysplasia we did a question on yesterday. I'm going to go back to that question. But generally speaking, angiodysplasia, angio, so it's a tortuous dilation of vessels. And when your vessels all get dilated, they're going to leak, so you end up getting hematochezia. most often found in the right-sided colon, more common in older patients. Confirm this with angiography, and this is also going to be often associated with aortic stenosis and von Willebrand disease. Now, the question we did yesterday, let me go back to it. I actually mentioned all of that, but it was a really interesting and weird question where if you couldn't think of angiodysplasia, you wouldn't really pick that answer choice. It was this one in the middle right here, right? It's a 79-year-old man with aortic stenosis coming to the emergency room because of worsening fatigue over 5 months. He has intermittent bright red blood in his stool, and he hasn't had any abdominal pain or weight loss. Physical exam is showing that he has anemia, and you get the crescendo murmur from the aortic stenosis. The abdomen is soft and non-tender, so there's no pain. And lab studies are showing anemia as well, mainly iron deficiency anemia. Colonoscopy would show no abnormalities, right? Because remember we just said it, that to diagnose this, you would have to do an angiography. And then they went and asked you which of the following is the most likely underlying mechanism of his bleeding. So you had to pick the tortuous submucosal blood vessels. It's angiodysplasia. Alright? So that's the question we did, I think, yesterday, in yesterday's video. So UWorld asked about it, and generally speaking, it is a pretty common thing. So this is going to be a case scenario where an elderly man is presenting with iron deficiency anemia, but colonoscopy is perfectly normal. If colonoscopy is normal and there's no polyps and there's no colorectal cancer, then you pick angiodysplasia as due to dilation of blood vessels. Colonic ischemia is pretty much the same thing we saw about mesenteric ischemia, but now it's the colon. So this is a reduction in intestinal blood flow causing ischemia. You'll have crampy abdominal pain followed by hematochezia, commonly occurring at the watershed areas such as the splenic flexure or distal colon. Typically affects the elderly, and you'll know something known as the thumbprint sign on imaging due to mucosal edema and hemorrhage. So what does the thumbprint sign look like? So that's, I think I have a picture right here, right? This one. And this is a barium enema study showing the thumbprinting due to colonic ischemia. So this is your large colon right here, and each of these white arrowheads is basically showing that you kind of took your thumb and just pressed in on the colon right there. So that's your thumbprinting. This also can be described as like the apple core, right? Where it looks like this was an apple. This little segment here was an apple, and you took a bite into it right here. Right, so two different things you want to make sure you remember if they mention either one of those radiographic findings. Let me see. Then you have ileus. Ileus is just intestinal hypomotility without obstruction. There's no obstruction, but the feces is not moving. So you get constipation and decreased flatus, distended tympanic abdomen with low bowel sounds, associated with abdominal surgeries, opiates, especially opiates because opiates do cause constipation, hypokalemia, and sepsis. Treatment is bowel rest, electrolyte correction, and cholinergic drugs that would actually stimulate intestinal motility. Right, so bowel movement may be stimulated by lactulose, erythromycin, or neostigmine. Any of these guys can cause more bowel movements and kind of fix the ileus. So it's really just a form of constipation, but there's no obstruction occurring. Meconium ileus is obstruction. Meconium ileus is a meconium plug which obstructs the intestine, preventing stool passage at birth, and you usually just see meconium ileus with cystic fibrosis, which was discussed long ago in biochemistry. The last thing here is necrotizing enterocolitis. This is seen in premature formula-fed infants with immature immune systems. They'll have necrosis of the intestinal mucosa, most commonly the terminal ileum and proximal colon, with possible perforation, which can lead to pneumatosis intestinalis, pneumoperitoneum, and portal venous gas. So basically air is entering all these areas that it's not supposed to be in. So how would you identify necrotizing enterocolitis? So I have two questions to help you see that. This one here is necrotizing enterocolitis. So you have a 3-week-old girl in the neonatal intensive care unit developing abdominal distension, vomiting, and blood-streaked stools. She had previously tolerated formula feeds and had normal stool and urine output. She was born at 27 weeks gestation, which is early, right, premature, to an 18-year-old mother. The pregnancy was complicated by premature rupture of membranes and preterm delivery. Abdominal x-ray shows thin, curvilinear areas of lucency that parallel the bowel wall lumen. Which of the following is most likely diagnosis? Now, when they tell you something about an abdominal x-ray having lucency, anytime an abdominal x-ray has any kind of lucency, that's a sign that the abdominal x-ray has air in the abdomen, right? You don't really need to understand what the curvilinear areas of lucency, don't get intimidated by it, blah blah blah. Just understand that the lucency in the bowel wall lumen means that there's air in the bowel wall, and that's what you're kind of seeing here. Right? You see the air, this is under the diaphragm now, but under the diaphragm there shouldn't be any air per se in the various portions, but there are, right? There's air kind of spread out in weird ways. This infant has pneumatosis intestinalis, air in the bowel wall, which can be seen on abdominal x-ray as thin curvilinear areas of lucency, and that's what the red arrows are kind of helping you see. The red arrows that parallel the lumen. In an infant with abdominal distension and bloody stools, this finding is diagnostic for necrotizing enterocolitis. So if I make this image bigger, right, you can kind of see, right, this portion right here, this little thin line right here is showing you one area of lucency, and this one right here, right? But the main thing is, right, this area having air was fine. This is basically that's just your stomach right there, right? Afterwards, though, you have intestinal air with like non-continuously, right? It's just like at random places, intestinal air at random places, and that's not really supposed to happen. Air shouldn't be all the way down here, right? So there's too much air in this lower area, and that's a sign of necrotizing enterocolitis, right? So bowel obstruction. The other question, this one from Amboss, I believe, is also the same thing. Yeah, this one is also necrotizing enterocolitis. So this one says a 24-day-old infant girl is brought to the emergency department because of a 2-hour history of fever, vomiting, and diarrhea. She has fed less and has had decreased urine output for 1 day. She was born at 33 weeks gestation and weighed 1,400 grams. Her diet consists of breast milk and cow milk protein-based formula. Examination shows abdominal rigidity, distension, and absent bowel sounds. Test of the stool for occult blood is positive. An x-ray of the abdomen shows gas within the intestinal wall. See, they just told you straightforward that there's gas in the intestinal wall. Gas in the stomach is okay, right? But there should not be any gas in the intestinal wall. There should not be any gas under the right side, because the right side basically would have your liver taking care of things, so there's no reason for there to be air there. But the left side has the stomach, so there could be air there. Which of the following is the most likely diagnosis? So then they explain that if you have air in the intestinal wall, that's indicative of severe inflammation. Air in the peritoneal cavity is suggestive of bowel wall rupture, and this patient most likely has necrotizing enterocolitis, the most common cause of an acute abdomen in premature infants with low birth weight. It typically occurs 2 to 4 weeks after birth, once oral feeding has begun. Infants present with poor feeding, lethargy, vomiting, diarrhea, and hematochezia, and or distended abdomen with decreased bowel sounds, all of which are present in this infant. X-ray of the abdomen showing pneumatosis intestinalis confirms the diagnosis of necrotizing enterocolitis. Other typical X-ray findings include dilated bowel loops, portal venous gas, which is another favorite of step 1. They'll love telling you air in the portal system, and abdominal tree air in the case of bowel perforation. Bowel perforation requires emergent laparotomy and likely resection of the affected bowel to prevent progression of bowel necrosis, DIC, and shock, all of which can ultimately just kill the baby, right? So you have to do surgery immediately and fix it. Okay, so make sure you kind of really get all these down. The ischemia ones are really easy. The ones that are worth remembering separately are just angiodysplasia and necrotizing enterocolitis. Those are the two that you have to remember, because those are two specific diagnoses that you can get on patients depending on how they present. And that's really all there is for now. In the next video, we'll go on into colonic polyps and look more into colorectal cancer.